Welcome to this explainer. We've designed this specifically to give you the high-yield, structured breakdown of the RCOG Green-top Guideline on Ovarian Hyperstimulation Syndrome, or OHSS. So if you're gearing up for your MRCOG exams, or honestly, if you just need a really concise, evidence-based refresher on managing this incredibly complex condition, you are definitely in the right place. We're going to completely bypass the fluff today and focus purely on the clinical decisions and those hard criteria you absolutely need to know.
Today, we are mapping out 5 key steps: diagnosis and assessment, classifying severity, outpatient rules, inpatient and fluids, and finally, severe complications. All right, let's dive right into Section 1, diagnosis and initial assessment. At its core, you have to remember that OHSS is not just about having big ovaries. It's actually a systemic vascular permeability issue. It's driven by pro-inflammatory mediators, with vascular endothelial growth factor, or VEGF, being the primary culprit, and this is usually triggered by HCG exposure. What happens is these mediators cause fluid to literally leak out of the blood vessels and into the third space. That leads to ascites, effusions, and just profound intravascular volume depletion. So whenever you're thinking about OHSS, keep vascular leak front and center in your mind as the root cause of all the symptoms we're about to cover.
Now let's look at a fascinating pathophysiology paradox, and examiners absolutely love to test this one. These patients are severely hypovolemic, right? Because they're losing all that fluid into their third space. So logically, you might expect them to be hypernatremic and hyperosmolar, kind of like someone who is just severely dehydrated. But they aren't. They actually present with hypoosmolality and hyponatremia. Why is that? Well, it's because this syndrome completely resets their osmotic thresholds for vasopressin and thirst to much lower levels. Seriously, memorize this triad. It comes up all the time.
When you're taking a history, you must make a critical timeline distinction. Early OHSS presents within 7 days of the HCG trigger injection. It's essentially an exaggerated response to the fertility treatment itself. But late OHSS, that presents 10 or more days after the trigger. And this is usually driven by the endogenous HCG produced by a newly implanted early pregnancy. The crucial takeaway for you here is that late OHSS tends to be much more severe and prolonged simply because that HCG stimulus is continuous and growing. Moving on to Section 2, classifying OHS severity. When you're classifying OSS severity, you really need to know these RCOG thresholds cold. Notice how mild and moderate OSS are mostly symptom-driven. You're looking at things like bloating, pain, nausea, and maybe some ultrasound evidence of ascites. But once you hit severe and critical OSS, it becomes heavily objective and lab-driven. The absolute crucial point here is the hematocrit. It jumps above 0.45 for severe OSS, and then it leaps above 0.55 for critical OSS. You'll also see clinical ascites, oliguria, and significant electrolyte derangements in that severe category, which then moves on to tense ascites, anuria, and even thromboembolism in the critical category.
Let's step into Section 3, outpatient management rules.
Managing these patients as outpatients relies on a few essential ironclad rules. Step 1. Fluid management here isn't about rigid IV targets. It's highly physiological. You advise the patient to drink to thirst, aiming for at least 1 liter a day. Step 2 is all about pain relief. You can absolutely use paracetamol or codeine, but you must strictly avoid NSAIDs. Why? Because NSAIDs block prostaglandins, which will severely compromise their already stressed and underperfused kidneys. And Step 3, regular monitoring. These patients need a clinical review every 2 to 3 days to check their weight, girth, and urine output. You're constantly making sure they aren't sliding into a more severe category.
Next up is Section 4, inpatient care and fluids. So, an absolutely crucial point for both your daily clinical practice and your exam scenarios is knowing exactly when you must pull the trigger on a hospital admission. You really cannot afford to hesitate here.
Admission is strictly required if they hit any of these exact criteria. It's not just about lab values, guys. If they have failure to control pain, they come in. If they have intractable nausea that's preventing that critical oral hydration we just talked about, they come in. If their signs are worsening despite your outpatient care, or even if they simply cannot attend follow-up for social or geographical reasons, you admit them. And obviously, anyone meeting the criteria for critical OHS needs immediate admission, very often requiring multidisciplinary or intensive care.
Once they are admitted, fluid management becomes a very delicate balancing act. Oral hydration still remains the first line and most physiological route.
But if they are acutely dehydrated and need IV volume expansion, colloids like human albumin 25% are recommended over crystalloids, mainly because crystalloids can just leak right out into the ascites. And let me give you a massive red flag for your exams right now. Strictly avoid diuretics in the initial management. Diuretics pull fluid from the intravascular space. In a patient who is already profoundly hypovolemic, giving them a diuretic can literally trigger cardiovascular collapse or acute renal failure. Just don't do it.
Finally, let's hit Section 5, managing severe complications.
When that third space fluid accumulation gets to be too much, we have to intervene mechanically. The indications for ultrasound-guided paracentesis are really clear. We drain the fluid if the ascites causes severe, uncontrollable pain. We drain it if the fluid pushes up on the diaphragm and causes respiratory compromise. And crucially, we drain it if the intra-abdominal pressure becomes so high that it literally compresses the renal veins, causing oliguria despite adequate IV volume replacement. Draining that fluid relieves the pressure and restores renal perfusion.
Now, prepare yourself for this staggering data point from the guidelines. 99.7. That is the odds ratio for a venous thromboembolism occurring in the first trimester for an IVF pregnancy that is complicated by OHSS when compared to a non-IVF pregnancy. That risk is, frankly, astronomical.
Because of that terrifying VTE risk, which is driven by intense hemoconcentration and endothelial dysfunction, administering low molecular weight heparin isn't just optional. It is a mandatory guideline intervention for anyone diagnosed with severe or critical OHSS, and for anyone admitted to the hospital. The duration of this should be individualized, but if they conceive, it's very often continued all the way through the first trimester.
And the vigilance doesn't stop just because the patient goes home. Even after the acute syndrome resolves, we must counsel our patients that OHSS casts a really long shadow. The guidelines explicitly state that pregnancies complicated by OHSS carry downstream obstetric risks, specifically an increased risk of preeclampsia and preterm delivery. We absolutely must plan their antenatal care with this in mind.
As we wrap up this explainer, whether you're sitting down for your MRCOG exam or assessing a patient on the ward, I want you to always keep this final provocative thought in mind. Never let OHSS become a lazy default diagnosis. If a patient presents with a fever or sudden agonizing pain, ask yourself, is this really worsening OHSS, or is there a surgical emergency, like a ruptured hyperstimulated cyst, an ectopic pregnancy, or a pelvic infection hiding underneath? Stay vigilant, stick strictly to the criteria, and trust the structured approach. Good luck!